Hello, my name is Ki-Jinn, and in this video, I would like to talk about one of my favorite blocks for anesthesia of the upper limb, the infraclavicular block. As with all my videos, the opinions expressed are my own and reflect my own practice. The purpose is to educate and to present one way of doing things, which may or may not be applicable to your practice. The infraclavicular block is a suitable technique for providing anesthesia or analgesia of the upper limb from anywhere just above the elbow all the way to the hand. It may be performed as a single shot block or a continuous catheter technique, with the scanning and needling approach being identical in almost all respects. It is an alternative to the supraclavicular or axillary brachial plexus blocks. With proper technique, the efficacy and coverage is the same for all three blocks, with the choice being made based on patient factors, a consideration of the associated adverse effects and risks, and ultimately, personal preference. There are three basic reasons why the infraclavicular block is one of my favorites. First, it is a very simple block to perform. The sonoanatomy, as I will show you, is easily recognizable. The block is essentially a perivascular injection around the axillary artery into two very discrete compartments. The block can be completed with minimal redirection of the needle, making it very quick to perform. The depth of the target is often brought up as a limitation, but this is not usually a concern in most patients as long as the artery can be visualized. Second, it carries a very high success rate as long as the correct compartmental spread is achieved. There is also often spread to the intercostal brachial nerve from T2 that supplies the inner aspect of the upper arm, with less tourniquet discomfort demonstrated in studies. Third, it is a very safe block. The pleura is a significant distance away from the neurovascular target, and thus there is a minimal risk of pneumothorax. There is a much lower risk of phrenic nerve palsy compared to blocks performed above the clavicle, although this may still occur with large volumes in smaller patients. There are some circumstances when one might consider alternatives. These include patients with a very thick chest wall, as imaging structures at more than 5 centimeters depth with a linear array probe is generally very difficult. However, a curved array probe will solve this problem. Coagulopathy is a relative contraindication, as the area is less easily compressible compared to, say, the axilla. The risk of vascular puncture will depend on personal expertise, and whether or not there are abnormal vessels in the planned needle path, which thus represents another factor to consider. Finally, the shoulder will not be anesthetized, which may or may not be an advantage depending on your perspective. Patients are able to abduct their arm, which may lead to movement during surgery, but it is also more reassuring to the patient than having a completely immobile upper limb. As with all regional anesthesia blocks, the essential preparatory steps need to be taken. For the infraclavicular block specifically, a linear probe is suitable in most patients, although a lower frequency setting with greater penetration may offer better image quality. A curved array probe is recommended if attempting the block where the target depth exceeds 5 centimeters. In all cases in adults, a needle of at least 80 millimeters length should be used, not a 50 millimeter needle. The usual volume of injection in adults is 20 to 30 mils, and I generally recommend higher volumes as this is a perivascular compartmental block versus a targeted perineural block. Finally, it is very useful to infiltrate skin and the pectoral muscles with a longer 25 gauge needle. This increases patient comfort. The infiltration needle can also be visualized on ultrasound, which helps with determining the correct trajectory of the block needle. The next thing to consider is how to position yourself in relation to the ultrasound machine and the patient. Ergonomics are very important in block performance. There are two ways in general to perform in-plane ultrasound-guided needling. The first may be called the along approach, where the needle is advanced along your site like throwing a dart. In this approach, the ultrasound machine should be placed on the same side of the patient that the block is being performed, and the operator stands at the patient's head. Research shows that the needle beam alignment is more easily achieved, and you can also use the same hand for needling no matter which side of the patient you are blocking. In the second approach, the needle is advanced across or perpendicular to your line of sight. The ultrasound machine in this case is positioned on the opposite side to that being blocked, and the operator stands on the same side that is being blocked. Here, depending on which side you are blocking, you may find that you have to use your non-dominant hand for needling. Although the infraclavicular block may be performed with the arm adducted, it is very much easier if the arm can be abducted. The clavicle moves superiorly and out of the way, and the neurovascular bundle also becomes more superficial, making it much easier to visualize the brachial plexus and to approach it with a needle. Note that the orientation of the neurovascular bundle also changes depending on whether the arm is abducted or adducted, and the probe should be rotated accordingly to get a true short axis view. When scanning to image the infraclavicular brachial plexus, it is important to realize that the anatomy of the cords varies along its course. Above the clavicle, the entire brachial plexus is tightly grouped lateral to the artery. This arrangement continues into the area just below the clavicle. As a result, if the proximal or medial portion of the infraclavicular brachial plexus is imaged, the cords will be seen clustered cranial to the artery. As the imaging plane moves more distally or laterally, the cords start to separate out and spiral around the artery into their positions lateral, posterior, and medial to the artery. The sonographic pattern will vary accordingly. In the proximal or medial portion, the entire plexus is clustered cranial to the artery in a crescent shape. The artery and vein are touching each other, signifying that there is nothing lying between them. And in this patient, note the presence of a little accessory artery in this individual, which is sometimes seen. More distally, the area deep to the artery starts to fill in as the posterior and medial cords rotate into this position. And even more laterally and distally, the medial cord will move into a position between the artery and the vein. The next important thing to realize is that the infraclavicular brachial plexus is located within two discrete fascial compartments. This post-injection image shows this quite clearly. The lateral cord is located within its own compartment, while the posterior and medial cord share a larger, deeper compartment. The key to a successful and safe infraclavicular block is to recognize, enter, and fill these two compartments with local anesthetic. The next few slides will illustrate the key sonographic landmarks to identify in the scanning phase. In this proximal medial view, you will see that the neurovascular bundle is always located just deep to the pectoralis minor muscle. With the probe in the medial location, the entire plexus is cranial to the artery as previously discussed. Even here, however, the lateral cord is structurally separate and lies within its own compartment. As the probe is slid more laterally, the posterior and middle cords move into position under the artery, while the lateral cord stays just under pectoralis minor and cranial to the artery. The two fascial compartments exist as illustrated. This is the view I prefer to obtain and use for needling, as the two fascial compartments are clearly identifiable and separate. Note that slight tilting of the probe is often required to optimize the image. The most important thing is to clearly see the boundaries of the artery and the plexus elements. Having obtained and optimized an appropriate image, needle insertion can now begin. Although the infraclavicular block has a reputation for difficult needle tip visualization, I think this is largely undeserved. An echogenic needle does help a lot, but as the following videos will show you, the needle tip position is easily ascertained by a combination of tissue motion, fascial pops, both tactile and visual, and hydrolocation with fluid injection. The endpoint is also very clear and easily achieved, namely local anesthetic spread within the two perivascular compartments. Although studies suggest that a single injection deep to the artery produces success rates that are statistically equivalent to a dual or triple injection technique, I recommend a dual injection technique because it takes no additional effort and contributes to a 100% success rate versus, say, 95%, which might not be statistically different, but is certainly clinically different in my opinion. The needle approach is summarized as follows. Advance the needle to skim past the lateral cord and reach the 5 to 6 o'clock or 6 to 7 o'clock position of the artery, depending on which side you're coming from. Injection in this location produces local anesthetic spread into the compartment containing the posterior and medial cord. The needle tip is then withdrawn to lie next to the lateral cord, and injection is performed here to fill this compartment. Let's look at it step by step. Pectoralis major and minor are identified, as is the axillary artery and vein. The lateral cord, posterior, and medial cord are located in their respective fascial compartments. The block needle is advanced through the pectoral muscles until it just pierces the deep fascia of pec minor, aiming to be oblique or tangential to the lateral cord. There should be a tactile and visual give or pop as the fascia is pierced. To avoid eliciting a paresthesia and causing potential trauma to the lateral cord, look to see that the lateral cord rolls away from the needle as you probe gently on the fascia before committing to piercing through it. Now, once the fascia has been pierced, inject 0.5 mL of local anesthetic to confirm entry into the compartment and to push the lateral cord aside. Continue to advance the needle towards the superior posterior aspect of the artery, in this case the 6 or 7 o'clock position, so as to cross the dividing fascia between the two compartments. It is vital to stay as close to the artery as possible so that the needle ends up between the artery and the plexus. Arterial puncture with a short beveled block needle is almost impossible at this angle and with appropriately gentle needle handling, and thus is of little concern. In any case, I would rather pierce the artery than the nerves. Correct needle tip position is confirmed by intermittent injection of 0.5 mL of local anesthetic. And when the tip enters the deeper compartment, this will be signaled by spread immediately deep to the artery, creating what has been called a double bubble sign. The second bubble of fluid pushes the posterior and medial cord bundle downwards and away from the artery. Once 15 to 20 mL of local anesthetic has been injected here, the needle is withdrawn into the lateral cord compartment, and a further 5 to 10 mL of local anesthetic is injected here to finish the block. A quick scout scan will reveal local anesthetic separating the artery and adjacent nerves from each other. What follows are some actual videos to illustrate these concepts. In this first one, you see the needle gently probing and advancing safely past the lateral cord. Hydrolocation can again be utilized to confirm entry into that lateral cord compartment and to push it aside. The needle is then advanced into the deeper compartment, and further test injections are performed to confirm entry into that compartment of the posterior medial cord, as signaled by the spread of fluid immediately deep to the artery. This second video is to show you how quick and simple the infraclavicular block can be, since it really only involves a single needle pass. The needle is inserted through pectoralis major and minor to pierce the pectoralis minor fascia just superior or cranial to the lateral cord. A small amount of local anesthetic injected here pushes the lateral cord aside, and the needle is again advanced further to the 7 o'clock aspect of the artery. Needle insertion is now essentially complete, and injection into the deeper compartment occurs. Once this is complete, the needle is withdrawn into the lateral cord compartment and 5 to 10 mils is injected here before withdrawing completely. Well, that's it. The simple, safe, and effective technique of infraclavicular block. What follows is some bonus material to illustrate catheter insertion, an alternative approach in case of difficult anatomy, and the use of a curved probe. If inserting a catheter, the approach is exactly the same as a single shot. The only difference is insertion of the catheter once injection into the deeper compartment has been completed. As always, the key landmarks are identified, including the pectoralis muscles and the lateral cord just deep to the fascia of pectoralis minor. The needle is advanced just past the lateral cord. In this case, the test injection spreading into the pectoralis minor muscle indicates that the fascia has not yet been pierced. With further advancement, entry into the lateral cord compartment is achieved. Fluid is injected to push the lateral cord aside and to anesthetize this lateral cord. The needle is then advanced towards the 7 o'clock aspect of the artery. I prefer to inject a total of 20 mils of local anesthetic into the posterior compartment to create a space for the catheter, as well as to initiate blockade of that posterior and medial cord. Once injection has been completed, advance the catheter 2 to 3 centimeters beyond the tip. This can be done blindly, or if an additional operator is available, can be done under direct visualization as you see here. The reason not to advance beyond encountering slight resistance is that the catheter may actually leave the space and travel too far, resulting in an unsuccessful catheter placement. Here the catheter can be seen lying in that deeper compartment just adjacent to the posterior cord. Injection through the catheter produces spread into that deeper compartment, which confirms a successful block. This next video illustrates that if necessary, the needle can be inserted from a caudal to cranial direction. In many ways, this is similar to the medial to lateral approach with a costoclavicular block. In this particular patient, severe rheumatoid arthritic deformities of the shoulder girdle have made supraclavicular and axillary approaches very challenging. Although the infraclavicular plexus can be easily visualized, the position of the clavicle also makes the conventional cranial to caudal needle insertion difficult. Careful needle handling is employed to pass the needle between the lateral cord and the artery. The overall concept remains the same though. Enter the lateral cord compartment to inject local anesthetic here. Once this has been achieved, continue to advance the needle into the deeper compartment. This will be signaled by local anesthetic spread deep or posterior to the artery. This third and last video shows the use of a curved probe in a larger patient. The pectoralis muscles, artery, and surrounding hyperechoic plexus are clearly visible, as is the needle. Local anesthetic spread deep to the artery is readily appreciated. Similarly, spread around the lateral cord as the needle is withdrawn into this compartment is also easily seen. With that, thank you for watching and happy blocking.